So I will introduce myself. My name is Emily Herzog, and I'm an Epic Pathways Program Coordinator here in the University of Michigan School of Nursing's Office of Health Equity and Inclusion. Before I hand things over to our incredible moderator, Dr. Ruchika Patel, I want to invite everyone to our upcoming Health Equity Leadership Series. This is our phenomenal lineup for fall 2023. And if you haven't already registered, you can do so by scanning the QR code on the screen, or there's also a URL here at the bottom. Our next speaker will be Dr. Lucinda Canty of the University of Massachusetts Amherst. And in her talk, Dr. Canty will be discussing the current state of maternal health, her research into the experience of Black women who experience life-threatening complications, and how everyone, all healthcare team members, can address racial disparities in maternal health. So if you're interested, I'm actually also going to put the link in the chat for you all to register if you have not already. And we hope you'll join us. We're really excited about the speakers and the topics for this year. So without further ado, let's pass things over to our moderator, Dr. Ruchika Patel. Ruchika is our Chief Health and Academic Equity Officer here at the University of Michigan School of Nursing.
Thank you. Thank you so much, Emily, for your work coordinating this. And to you, Dr. Hagiwara, welcome again to the School of Nursing, and thank you for joining us. I'm really excited about your presentation. Implicit bias training, DEI training is everywhere. So many of us have our hands deeply in it, even providing it. And to be able to grow from your research is such a wonderful opportunity for us. So just in advance, thank you so much for being here. I'm just going to briefly introduce you and then kind of turn it over to you to sort of take us through your work. Dr. Hagiwara is a professor of public health sciences and director of the program on health disparities and community engagement research at the University of Virginia. She is a leading researcher in the field of healthcare providers' bias and racial disparities in healthcare and health. With a training background in basic experimental social psychology, she grounds her applied disparities research in social psychology theories of stereotyping, prejudice, and discrimination. To date, she has obtained multiple NIH grants on provider implicit bias and published over 60 peer-reviewed journal articles and book chapters. Her recent work on provider implicit bias has appeared in flagship journals, including the Lancet, as well as popular media outlets such as CNN and the New York Times. She is a recipient of a 2023 Diversity in Research Award from the Social Personality Health Network. Thank you again, Dr. Hagiwara, and welcome. I'll turn it over to you.
Thank you, Ruchika, and thank you so much for the opportunity to present my work to your colleagues. And Emily, thank you so much for organizing this talk series. Let me see if I can share my screen. I practiced this, so it should work. All right. Can everybody see it? Okay.
Yep.
Great. All right, so I'd like to start my talk today by acknowledging my collaborators and the funders. And I want to give a special shout out to Drs. Green and Penner here with pictured, who continue to push me to challenge my research boundary. Okay, and before I start my talk, I want to tell you a little bit about me so you can have a better understanding of how and why I take a specific social psychological approach to study racial healthcare and health disparities. This is me back in 2000 when I came to the United States to study psychology. And my career goal back then was to become a clinical psychologist, but that quickly changed. I went to a small university called Morehead State University, which is located in the Appalachian region in Kentucky. So coming from Tokyo to a small Appalachian town in Kentucky, explains a drastic change in how people treated me. In Japan, if you know the country, is such an ethnically homogeneous country. And I was always part of the majority group. But in Moorhead, Kentucky, I became part of a minoritized group. I experienced the racial discrimination on multiple occasions. And those experiences were heartbreaking, but at the same time, they were extremely intriguing personally. So based on these personal experiences, I decided to pursue my degree in social psychology to study intergroup bias. So I study healthcare and health disparities from this social psychological perspective. And I believe that the first important step in discussing implicit bias training is to discuss what we mean by implicit bias. This is because some of the definitions used in health and healthcare disparities research are inaccurate. There are 3 elements of intergroup bias that correspond to the ABC of psychology: affect, behavior, and cognition. The first is stereotyping, which is the cognitive element of intergroup bias. Stereotypes are beliefs or expectations that we have about other people's personal attributes or characteristics based on their membership to a certain social group. And those groups can include anything from race, ethnicity, religion, gender, to sex and sexuality, to name a few. The world is really complicated, so it is really hard for us to process all the information. And also having a differentiated expectation about everything actually is not beneficial to human evolution. So humans have evolved to maximize our cognitive time and energy by relying on heuristics, or what's called mental shortcuts. And here is an example of mental shortcut we often use. So I would like you to visualize a cheerleader now, and I will give you about 10 seconds. Okay, so I hope everybody has a mental image of a cheerleader now. Okay, let me describe the picture you might have in your mind. I think the person is a young, petite, and a skinny girl. And maybe she has a long hair, even with a big bow. I have to acknowledge that there are some variation in the pictures each of you have in your mind, but I bet none of you had this image. How about a compassionate nurse? I will give you another 10 seconds so you can come up with a mental image of a compassionate nurse now. Okay. With this one, there may be even more variation across people's image, but I think many of you are thinking of a woman now, maybe middle-aged woman, but I think very few of you had this image. Now, I think you got the point here. We have stereotypes or mental shortcuts about many different social groups. As the examples demonstrated, stereotypes can be positive, although we tend to notice more negative stereotypes. And again, stereotypes can be adaptive if we use them correctly, but they can become a serious problem when they are inaccurate or when they are just overgeneralized because they blind us to individual differences within a class of people. Next, I will talk about prejudice, which is the affective component of intergroup bias. Prejudice is negative feelings or even hostile attitude toward a group of or its members. When you hear people say that they don't like someone just because they are from a certain social group, that's a prime example of prejudice. And people can have a prejudice toward any social group or its members, including group as rapists or KKK members. It is just that prejudice toward certain groups is accepted or even expected in our society. And finally, discrimination is the behavioral component of intergroup bias. Discrimination is unjustified negative or harmful behavior toward a group or its members. Note that an intention is not part of the definition of discrimination. So people can discriminate others with or without an intention to harm others. In other words, not all discriminatory behaviors are results of negative stereotypes or prejudice. People can still act in a discriminatory manner when they are following discriminatory institutional practices, which is called institutional discrimination. Now, all those three components of bias, stereotyping, prejudice, and discrimination can operate at two different levels, controlled and automatic levels. And bias at the control levels are considered as explicit process that are deliberate, reflective, and sometimes effortful. On the other hand, bias at the automatic level are considered as implicit process that are effortless, habitual, and spontaneous. Now, I have prepared a quick activity for all of you to experience both the automatic and controlled processing. And this is called a strip test. And just a heads up that this test is designed only for people who can differentiate colors. So please pardon me for not preparing a more inclusive activity. On the next slide, you will see a series of words in different colors. Your task is to say aloud the color in which each word appears as quickly and accurately as possible. Your task is not reading each word. And I would like you to move from the top row, left to right, then move on to the next row, left to right, and then next row, left to right, and so on. And for you to be able to experience what the automatic versus controlled processings are actually like, I really encourage you to say aloud the color of each word if possible. Okay, ready? 3, 2, 1, go. I hope that was enough time for everybody. On the next slide, you will repeat the exact same task. You will see a series of words in different colors. And your task is to say aloud the color in which each word appears as quickly and accurately as possible. Okay, 3, 2, 1, go. Sure that you had no problem completing the first slide, but I believe that the last slide was more difficult. This is because the first slide reflects our automatic habitual process. We are pretty good at identifying colors unless individuals have color blindness because we were taught to name colors since we were toddlers. We are also expert readers because again, we were taught to read very early on. The last slide was difficult for many of us because it forced you to switch from the automatic processing to the controlled processing. When words and colors are presented simultaneously, our habitual dominance response is to read. Paying attention to the colors is a secondary response. So you had to inhibit and override the initial desire to read with naming colors. The distinction between controlled and automatic processing is directly applicable to the three elements of bias. That is implicit stereotyping, prejudice, and discrimination are rather spontaneously and habitually activated, and then they are harder to regulate than explicit stereotyping, prejudice, and discrimination. However, just like the last slide in the strip test, it is not impossible to regulate implicit stereotyping, prejudice, and discrimination. We just need to engage in effortful and deliberate regulation of those biases. And the next slide, I prepared the demonstration of what's called IAT, implicit association test. When I talked with Emily, she mentioned that some of you might not have experience with IAT. I wanted to show you this because this is one of the most widely used measures of implicit prejudice, affective component of automatic processing. And the real IAT is administered on the computer and you are supposed to do it in a quiet space alone. But for the demonstration purpose, I modified a task. So here you will see either word or picture, face, one by one. And the first thing will appear on the top here. And then counterclockwise, you will see word or picture. Okay. And I want you to say either left or top left if you see word that represent that concept. And or if you see pictures of black faces. And then if you see white faces or good words, I want you to say right or top right as accurately and quickly as possible. Okay, and it will go very quick. So I would like you to try your best to keep up with it. Okay. 3, 2, 1, go. Okay. Now you will do the same task, but the pair is switched. So this time you will say left if you see bad word or white faces. You will say right or top right if you see good words or black faces. 3, 2, 1, go. Okay. And you can actually computerize the IAT by just going to Project Implicit. You can just Google Project Implicit, and the first thing that comes up is the demonstration side. And the premise of the IAT is, again, based on the reaction time, this trying to capture the spontaneous habitual response. And again, the premise is that people will respond faster if they have a more positive attitude toward black faces after seeing positive face, or react faster if they have negative feelings toward black faces, black people between bad words and black faces. Okay. So that's called IAT implicit association test. Now I'm going to go back to the actual talk, the content. So distinguishing different types of bias is very important because each type of bias is associated with different aspects of the patient care. And particularly, my recent narrative review revealed that explicit stereotyping here often predicts clinical recommendations. For example, providers who falsely believe that Black people are more likely than white people to be sexually promiscuous were less willing to prescribe PrEP. Likewise, research conducted here at UVA has shown that healthcare providers and trainees who falsely believe that Black people are biologically different from white people were less likely to be accurate in treatment recommendations. The narrative review also revealed that the provider's implicit prejudice is associated with patient-provider communication. For example, Black patients reported significantly lower levels of satisfaction with care and trust in providers after interacting with providers with higher as opposed to lower levels of implicit prejudice, which was assessed with IAT. And finally, there is some evidence suggesting that although explicit prejudice does not predict patient-provider communication directly, it may moderate the association between implicit prejudice and patient-provider communication. Specifically, providers who fit what's called aversive racism profile, which is high in implicit prejudice, but low in explicit prejudice, are perceived least favorably by Black patients. Okay, so this is what we know in the literature. But inconsistent with these literature findings, many implicit bias training programs aim to address both disparities in treatment recommendations and patient-provider communications by solely focusing on implicit prejudice. I am also currently conducting a systematic review of implicit bias training, specifically in the context of healthcare. We found a total of 62 empirical papers published between 2003 and 2021. We decided to start with 2003, which was the year the seminal report on equal treatment was published. And we also did a follow-up, 1-year follow-up review, and we found that there were 15 published papers just within the last year. So there has a significant increase in interest in implicit bias training in the field. So what we are finding, so we are currently synthesizing the results. So this is just the preliminary findings presented here. But this is the typical characteristics of current implicit bias training. Okay, so the majority of training uses a combination of didactic and hands-on activities, but they tend to focus more on educating attendees what implicit bias is and how it could impact their patient care. Okay, and the training also vary in frequency and duration. The majority of training is delivered at the single time point that lasts only for an hour or two. And now going back to the Stroop test you completed, even simple tasks such as overriding our urge to read words and instead to name colors became quickly awkward. And to perform the Stroop test perfectly, we need to practice repeatedly. Now imagine that you have to override several paraverbal, nonverbal, and verbal behaviors simultaneously to manage the manifestation of implicit bias. And there are training programs that breaks up the learning objectives into multiple parts, which are delivered over multiple days. But such training is still an exception, not the norm. And finally, the effectiveness of implicit bias training is often assessed with self-reflection, meaning that attendees are asked to reflect on their own implicit bias and report how they think the training would change their patient care in the future, would have changed their patient care in the future. And some training programs also assess their effectiveness by measuring changes in IAT scores between pre and post-training. But there is no scientific evidence at this point to suggest that the current implicit bias is effective in reducing the actual healthcare disparities. And unfortunately, this is not surprising at all, and I will explain why there is no evidence at this point. Development and implementation of successful implicit bias training should be understood within the clinical and the translational scientific framework, which consists of 5 stages. Of the 5 stages, T1 to T4 are particularly relevant to the development and the implementation of implicit bias training. In the context of the development of effective implicit bias training, T1, which is translation to humans, is often done in the field of basic experimental social psychology. The goal of this stage is to identify strategies driven by theories to reduce implicit bias in general populations. And when I say general populations, oftentimes that's done with Psych 101 students in social psychology. And T2, which is translation to patients, aims to develop implicit bias training on the basis of findings from T1, and then to test its effectiveness with healthcare providers and professionals. The goal of T3, which is translation to practice, is to evaluate the effectiveness of implicit bias training after it is adapted into the existing curriculum and training. And finally, T4, which is translation to community, aims to optimize the training effectiveness in larger populations. In the rigorous clinical and translational science framework, each stage should inform other stages, but the translational gaps exist among all 4 stages in the ways the current implicit bias program were developed and being implemented. The first translational gap exists between T1 and T2. This gap reflects inconsistencies between findings from basic social psychology research of implicit bias and the content of the current implicit bias training. Again, the typical implicit bias training is a combination of didactic and hands-on activities, very brief and focused on increased self-awareness or reduced IAT scores. But this is inconsistent with what we know from the basic research on implicit bias, which suggests that implicit bias is just like an old habit. To effectively reduce any habit, people have to be provided with concrete strategies and be given opportunities to practice them repeatedly over time. In the specific context of implicit bias, evidence-based habit-breaking strategies include stereotype replacement, counter-stereotypical imaging, individuating, perspective taking, and contact. Social psychology research also provides strong evidence that awareness is necessary, but not sufficient in reducing implicit bias. People also have to be motivated to reduce their bias and have enough cognitive resources to practice the habit-breaking strategies. And this makes sense because even if we were aware of our implicit bias, if we were not motivated to reduce it, training is meaningless. And likewise, even if we were aware of our implicit bias and were motivated to reduce it, if we were too tired and lack cognitive ability to practice habit-breaking strategies, training still cannot produce the desired outcomes. The next 2 translational gaps exist between T2 and T3. One gap reflects the inconsistency between the actual and the intended goals of implicit bias training. Given how the effectiveness of the current implicit bias training is assessed, the actual goal of implicit bias training is to either increase awareness about one's own implicit bias or reduce IAT scores, or both. But I believe that the intended goal of implicit bias training is to improve the quality of care for patients, particularly from marginalized social groups. The other gap reflects the inconsistency between the goal of the current implicit bias training and the overarching goal of the healthcare system in the United States that seeks to maximize revenues. To maximize revenues, many healthcare providers are scheduled to see a large number of patients in a short period of time. And this high-pressure environment makes it difficult for any healthcare providers to engage in evidence-based habit-breaking strategies. Specifically, healthcare providers who don't have adequate time to get to know their patients have a limited ability to engage in individuation or perspective taking. Additionally, many healthcare providers operating under the constant pressure have chronic stress. And the stress is known to reduce people's ability to exert self-regulation, which is at the core of overriding habitual responses. These considerations suggest the situational irony that implicit bias training as currently designed might not be an effective or even realistic approach to rectifying the negative effects of implicit bias. This issue leads to the another translational gap between T3 and back to T1. And finally, the last gap is between T3 and T4, which reflects the lack of rigorous testing of external validity. T4 is a very critical stage in order to ensure that the training can be generalized beyond a given study population. Specifically, T4 enables us to optimize the effectiveness of an implicit bias training program for individuals at medical schools and healthcare providers in different geographical regions by taking into account diverse institutional, social, and cultural norms. And ultimately, I believe that the most successful implicit bias training is also the most far-reaching one. However, currently, our systematic review revealed that no study to date tested the external validity of their implicit bias training programs beyond their samples. In sum, there are multiple translational gaps across all stages. But how do we actually start to address these gaps? I think we need to take a step back and start from the initial stage. So the first step is to redefine the goal of implicit bias training. Again, I believe that the goal of the training should be to improve the quality of patient care, not to increase the self-awareness or reduce the IAT scores. And patient care can be further broken down into two aspects: clinical recommendations and patient-provider communication based on evidence in the current literature. Okay. And because the current implicit bias training primarily focuses on implicit prejudice, I will first focus on this link between implicit prejudice and the patient-provider communication. So once we define the goal of the implicit bias training, the next step is to identify scientific evidence that informs the intervention design. And one way to improve patient-provider communication is to reduce healthcare providers' implicit prejudice. And as I mentioned earlier, social psychology research provides evidence that reducing implicit prejudice requires three things in addition to increase the awareness. First, high levels of intrinsic motivation to reduce one's own implicit prejudice. Two, multiple opportunities to practice habit-breaking strategies. And the three, adequate cognitive resources. And given the limited time that I have today, I won't be able to review scientific evidence for each of these conditions, but I'm happy to talk about it later during the Q&As if anyone has a question. Okay, so one important caveat here is that because the effectiveness of implicit bias training is generally assessed with either self-reflection or IAT scores, as discussed earlier, it is yet to be tested whether the reduction in implicit prejudice would actually result in improved patient-provider communication behaviors. So our next step is to determine the feasibility of the ideal intervention that's grounded in identified scientific evidence. So in theory, the ideal intervention is to target the root cause of the issue at hand, which is implicit prejudice among healthcare professions. But in practice, many healthcare providers wouldn't have the time or cognitive resources to practice multiple habit-breaking strategies unless we can change the current healthcare system. So unfortunately, the ideal intervention that aims to reduce implicit prejudice is unlikely to be feasible. So what's the best alternative approach? I argue that the best alternative approach is to directly target healthcare providers' communication behaviors. Once we identify the alternative approach, then we can go back to the earlier stage of a clinical and translational research framework and identify the relevant scientific evidence informing the intervention design. And again, because of the time, I will not go over the literature of behavioral change now, but I am happy to talk about it later. Okay. Next, the validation of intervention has to be done correctly to ensure that the intervention is actually effective in achieving its goal. To do so, it is critical to select appropriate assessment tools that directly assess the desired outcomes, which is patient-provider communication, not self-reflection or IAT scores. And there are several ways to assess the quality of a patient-provider communication. One way is to code providers' communication behaviors and assess the degree to which providers displayed positive versus negative communication behaviors. If the training increases the positive communication behaviors and reduces negative communication behaviors, the training can be considered successful. Another way to assess the quality of patient-provider communication is to ask patients to report their satisfaction with care or trust in providers after the encounters. Successful training should be able to increase patient satisfaction and trust overall. Finally, researchers are encouraged to test the external validity of implicit bias training they developed beyond the original study population. As I mentioned before, an increasing number of scholars and even policymakers are interested in implicit bias training. And actually, number of states, including Michigan, either mandating or at least had introduced the bill in the past to mandate implicit bias training for healthcare providers. And some of those states are using the exact same training. However, as you can see on this map, people undergo such training from diverse geographical locations, which we know are associated with different social norms. So it is naive to believe that implicit bias training that has been validated in one specific geographical location with a particular set of norms is also effective in another location with a very different set of norms. In order to have a far-reaching effect, we have to scientifically test the external validity of implicit bias training, and if necessary, adjust the training to optimize its effects. And I also have additional notes. I know I'm running out of time, but I think this is an important point. So going back to the conceptual model that I showed earlier, patient-provider communication was just one aspect of healthcare disparities that's associated with providers' implicit bias, particularly implicit prejudice. Another aspect that was associated with provider bias was clinical recommendation, particularly explicit stereotyping. So scholars and researchers who are interested in reducing healthcare disparities should take a multi-angle approach in order to fully address healthcare disparities. And the development and the implementation of training that aims to improve clinical recommendations should go through the same 5 steps as for the training that's aiming to improve patient-provider communication. But I want to highlight one particular translational gap here. In theory, equitable treatment can be achieved by reducing explicit stereotyping among healthcare providers. But in practice, medical students and trainees are taught to use race for formulating their clinical recommendations, even though race is a socially constructed factor, not a biological factor. So the effects of intervention at the provider level is likely to be canceled out without reforming the current medical education and training. And this suggests that the intervention have to also take a multi-level approach. So in sum, it is critical to take a multi-angle and also multi-level approach to provider bias in order to fully achieve equity in healthcare. Thank you for your attention.
Thank you, Dr. Hagiwara. That was so interesting, and my mind is moving in so many different directions, and I can't wait to actually receive your slides if we'll be able to receive them and look them over, because there are so many points of information that I want to understand more deeply, and I think many of us in the room will want to as well. We're going to open it up. Thank you again for your presentation. So you should know that you're joined today by students as well as faculty and staff.